my ways, so predictable. I can't release any emotion that I'll keep in this sky. You make me more than I am, more than a fool who is sick. I've been way too long on the subject of loving, babe. Loving, babe.
So welcome back to APCCC 22. We're here on the beautiful shores of Lake Lugano. I'm joined now by my old friend, urologist Dr Axel Merseberger, who's the chair of the Department of Urology at Lubeck University in Germany. Axel, nice to see you again in person, for real.
Declan, same wise here, and it's not a virtual background today. It's real. Huh?
Shall we enjoy the view for a second? Let our viewers on YouTube. I'm sorry for those of you listening on Spotify, but we are on the shores of this most beautiful part of the world, in the southern part of Switzerland. We've got these beautiful mountains behind us, and Lake Lugano just perfectly still. It is gorgeous, isn't it?
So you join hiking in the afternoon?
Yes, I think I'll go
Perfect.
hiking in the afternoon, or maybe I'll get the train up and hike down. Are you doing the hike up and hike down this big mountain?
I have an excuse when it's starting to rain. I do the.
Yeah. So we are actually at the conference. In fact, if we turn the camera around, you'll see the conference center is right behind us, but we literally are here. So it's the day 3 of APCCC 22. Axel, fantastic meeting as ever. What are your thoughts?
Well, honestly, it's my first APCC meeting. It's a pandemic. We were all virtual, so I think it's a great conference, and kudos and really congratulations to Silke and Aurelius for setting this up, and the organization is perfect. I think it's a role model for congresses post-pandemic now. We meet, we exchange, but we have the hybrid format, so excellent. And the content, superb. Experts from world, like 120 experts on prostate cancer. What do you want more?
It is, because it's a slightly different format to other meetings, isn't it? But I think they've nailed it. The attraction of these very short talks, only 10 minutes, 12 minutes. So some of these key opinion leaders are used to doing 20, 25 minutes on their topic, which they lead the world in. But condensing it into 10 minutes is attractive for us as delegates as well. You get 10 minutes on genomics and 10 minutes on whatever it's going to be. But then the discussions are just amazing, because as they put up the votes, so the panel always vote on how we think we should manage certain complex situations, which are not always clear. Sometimes the evidence is not there, so the consensus can be very helpful in guiding real world practice. And then those discussions tend to fuel questions about trials and research, and we've seen a lot of that, people trying to work out what's the best endpoint, what should we do, and what we see is months later, a year or two later, that trial has happened. People are sitting around at this conference and planning that. So I think that is important to be in a physical meeting to have those sorts of relationships, isn't it?
Fully agree, and I think some of the discussions and slides and consensus are eye-openers. You remember the slide which looks like a perfectly distributed cake with I think 15% for each vote, showing like how heterogeneous the expert voted on, and this example was post-failure in radiation therapy. What do? You take out the prostate, you radiate again, you do brachytherapy, you wait and see, you give ADT or intensified treatment. So it really shows where you have data gaps, or where we have data gaps, and I need to run clinical trials probably.
Yeah, because what tends to make the headlines on Twitter and when the big manuscript comes in a few months' time is the consensus, when we've reached 75% on this. But in actual fact, I really like your point, because when an expert panel has complete lack of consensus, well, that probably tells you that's where the next important research questions are going to be, so that in a year and 2 and 4 years' time that there is consensus on how to manage those patients. So now you're a urologist like me, and you're very interested in advanced prostate cancer, including metastatic disease and management of metastatic disease. So in the metastatic hormone sensitive setting, Axel, which you know a lot about, here again at this meeting we're seeing, of course, this very impressive data on combination therapies, let's call it that, because for 6 or 7 years now we know that doublet therapy, as we call it, ADT plus add in something else, AR pathway inhibitors, docetaxel, is really, really effective for improving survival for our patients. And now in the past year we're seeing, okay, what about triplet therapy? What about, blah, blah. But the really big issue, one of the big concerns I think I have as a urologist, is the lack of utilization of even doublet therapy. And we've just got a piece coming in Nature Reviews Urology covering this topic. It shows data from Australia, from Canada, from the US, from all over, showing that despite the data, and even taking away reimbursement concerns, probably only about 20-25% of newly diagnosed metastatic prostate cancer patients are getting access to combination therapies. My question to you as a urologist is that our fault? because we're usually the gatekeepers. We are the ones who diagnose these men. Is part of the reason why the utilization is low because the urologist is just prescribing ADT?
It could be a reason, but I think it is multiple reasons behind that. And we have discussed this here intensively, as you know. And as you said, some reimbursement issues or hurdles are associated with this. That's why, for example, when you look at the data from the US, where you expect up-to-date treatment, that's the other way around. You have European, Australian data, which is more like up to the guidelines recommendation to treatment intensification. And I chatted with some colleagues from the US, and they said, okay, it's difficult, more difficult than doing a radical prostatectomy than just going through all those forms to getting approval for apalutamide, enzalutamide, or abiraterone as a urologist. So that's why sometimes it's just ADT, which is disappointing. So I think also the regulatory need to change. It need to get easier because in Germany, when it's approved, I just prescribe it and don't have to run an application or go to the payers or something. I just prescribe it and the patient can get it. So I think education-wise, we are up-to-date urologists. I would say yes, definitely. And the ones that treat systemic MHSPC up-to-date, and I think it's just something what has changed and is getting picked up by the guidelines since a couple of years. So I think it will change, and hopefully towards treatment intensification. Another story is a triplet. Whether or not we need or who gets it, that's a different story.
Yeah, and that's my view on that. We wrote a piece about this. Some of our fellows did recently in Words of Wisdom in European Urology, saying, look, if we can't even get doublet right, how are we going to have triplet? Let's, if nothing else, if triplet does nothing else, it should reinforce our minds to say, well, let's get the doublets up to. So the other thing I think that has changed in the past year or two, and we see it in the voting a bit as well, is while, of course, the doublet therapy includes all the AR pathway inhibitors nowadays, plus docetaxel, you can really see people are really focusing down on the AR pathway inhibitors. That is the chosen doublet of choice. Yes. And that's the one where it's not reimbursed all over the world, that we can get access to. And even abiraterone is still not generic in all regions, not generic in Australia, still expensive. So that being said, let's imagine a world where AR pathway inhibitors are reimbursed and available in your country, wherever you're listening to this podcast or watching on YouTube. And you're a chairman of urology in your department, and you've got your trainees, your fellows, your residents, and you're trying to say to them, I want you guys and girls to embrace combination approaches for men with metastatic hormone-sensitive prostate cancer.
Yes.
Because I can tell you, what I sometimes feel is that they go, that's a bit complicated. You just refer them on to medical oncologists, because what's the one that you need the steroid with, and what's this about monitoring the blood pressure and the blah, 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 blah. But in my mind, we are the experts at hormone therapy. That's what urologists have done for the last 50 years. We've also added in the anti-androgens with bicalutamide and these sorts of ones. And it is not a great extension for us to say we must train the young urologists, maybe listening to these podcasts, to learn about this management. Because if we don't, first of all, we might fail the patients by not having appropriate treatment if we don't send them on to somebody who might prescribe that. And second of all, I think we miss an opportunity to keep these lovely men with us and make sure they get best care. So that's my question to you. How are you going to inspire your young trainees, the ones coming through, to say, don't ignore this, don't try and send it on to medical oncology. Do if you want, but understand we urologists can manage AR pathway inhibitors. I can tell now the medical oncologists listening will be cringing, but it's a true point.
It's really depending on the region and where you work and what the situation is. And maybe I'm not the right person to interview on this point, because I work and live in Germany, where traditional hormone treatment and also systemic treatment in GU cancer is mainly be done by urologists. So that's a different situation. So I have patients with metastatic prostate cancer, which I receive, and I get referred from my medical oncologist, because he said, I'm focusing on something else, leukemia and so on, and you do your GU oncology. So that's comfortable situation, and I think it's in Austria, Japan, and
Canada a little bit,
and some centers. But this is something what is unique for Germany, and so I think. But it's important because, as you said, we see those patients, we see those men first, and we need to be up to date at least about the data. And I think when you do systemic therapy in advanced kidney cancer, like pembrolizumab, axitinib combinations, it's a piece of cake to just give doublet. In prostate cancer, NHT and AR inhibitor, and just check, for example, as you mentioned, a couple of weeks later, the lab values when it's abiraterone or prednisone. So I think it's not really complicated, but I think we need to offer our men like up-to-date guidelines, recommended treatment, and not under-treat them.
Fantastic.
I mean, we learned that it's years you can win. Like yesterday, Karin Fizazzi presented again the Piece 1 data, 1.5 years overall survival when treatment intensification is performed.
So the last thing I want to ask you about, because apart from your interest in GU cancer, urology and so on, is you're very interested in online education platforms. You have been a very prominent leader in the development of some of these platforms around the place. You're a very good communicator. So COVID has led to challenges in education, but also these opportunities. We enjoy doing podcasts and so on, but what sort of online platforms do you like, or what changes do you think we could do to make this type of education more accessible to people as they go to work in the morning or they exercise in the gym and so on?
So I need a minute for answering your question because I had a smile because you were really the one getting me into Twitter. I started in Lubeck 7 years ago and I didn't know what a hashtag is. So I didn't know what this sign is and what it meant. And I had a young team and I thought, no, I still have a young team, but I thought it can't be that I don't know Twitter or YouTube, you know that, or Instagram or even TikTok. And so I think it is important to know what your residents are doing. And I picked that up and I found it quite, especially as you mentioned, quite useful in the pandemic. And I think everybody learns different. Like some listen to podcasts while they are commuting to work for half an hour and learn a lot. Me personally, I like those visual graphics, which you're an expert in, or your Wild Wild West presentation from ASCO-GU a couple years ago when everybody was expecting those blue and yellow slides like American style, you came with this motivating talk and it was all over on Twitter. And I mean, it's something where you can disseminate data, where you can educate in different formats, and somebody likes to listen to podcasts, somebody likes to listen to YouTube videos, somebody likes to just read a tweet in a summary, and everybody just has limited abilities. Like, what are your take-home messages from this conference? For me, it's maybe 5. I can tell you tomorrow. Yeah. Sure, I can do research and look at all the other presentations again, but it's mainly from conferences about to 5 to 10 take-home messages that you take home for your folks, for your patients, for your peers. So I think all getting involved in all those formats gives you an opportunity to stay up to date and choose the right format, whatever works best for you, whether it's a podcast, whether it's a visual poster, whether it's a tweet, or even, I don't know, may I ask you, are you investing in TikTok?
Yeah, not really, but I think we should. I think somebody younger than me should, because, and look, I love all the comments you just made about whichever format's comfortable. So I think for us as clinicians or educators, if we have messages to get out, I mean, you can create content like this, like a video and that, but you can deploy that out in different ways on TikTok and Instagram and tweak it for Twitter and so on. So TikTok, though, is very, very popular. And I think with our younger trainees, medical students and trainees coming through, that will be a format. I love video, so maybe we will do TikTok. I think it just looks a bit too cool for me. I'm a bit old for that, Axel.
I'm also a little shy, but when looking, for example, at my colleague Thorsten Schlomm from Charité University, he's on Instagram. I mean, he's a chairman of the Department of Urology in Berlin, Charité University, those big university, and he's on Instagram in a T-shirt and educating about what is a PARP inhibitor. Yeah. And I think some listen rather to this format than just reading a review. So I think it's important to just use the power of the technical things. I know you like techniques.
Yeah, well, exactly right. And we'll put links into Axel's Twitter handle. Please follow him. And I must just finally say to you, one of the most useful things I've seen you do in the past year or two is coming up to major conferences when abstracts are released for ESMO and ASCO or ASCO-GU. You send out a tweet where you say, here are my top 5 prostate cancer ones, the ones to watch, not just the summary afterwards, because I find that very helpful when you're trying to think, oh, maybe I'll just attend online, and rather than go through the program trying to find the things. I follow Axel Merseberger, and because I know the stuff that he's interested in, I'm really interested in. So there you go, bang, straight away. So I think that's a good one, doing it beforehand as well. That's a really effective, a nice trick that you do.
But it's surely biased. It's biased because it's my interest, but I think it's whom you follow, for example.
That's why Twitter's good, exactly. You follow people who you know, well, stuff they tweet out is going to be of interest to me.
And when it's too much noise, you unfollow me. And
exactly.
I think thank you.
Great. Thank you so much, Axel, for joining us here. And follow Axel. He's got fantastic tips and tricks. Thank you.
Nice seeing you live again. Thank you.
So So Jane Fisher, thank you for joining us at APCCC.
Oh, it's an absolute pleasure. It's great to be here.
Yeah.
Good to see you.
So you work with Movember back in Melbourne. Tell us a bit about your role, what you do with Movember.
So I joined Movember last year as Global Director of Cancer Research and Clinical Trials, and really head up the group of researchers within Movember who run our global action plan programs and support the clinical research that we do within Movember.
Yeah, which of course is such valuable work, all these great GAP programs, plus all the other independent research that you fund all the way around the world. And you're here at APCCC because obviously it's a fantastic meeting for prostate cancer, but this morning on the second day, you kicked off a fantastic session with an update on the Ironman registry. Can you tell us a little bit about Ironman and where we are today?
Yeah, so Ironman is a clinical quality registry, a global registry, and Movember are one of the major funders for Ironman, and it's a registry that's really focusing on a broader patient population, looking at men with advanced prostate cancer and the impact of their treatments and their treatment journey with prostate cancer, and really focusing on patient-reported outcome measures, which doesn't typically happen in a lot of clinical quality registries, as well as PREMs. I think one of the key points that Dan made today was with Ironman, it's got such a wide network, so they're not only looking at patients from Caucasian backgrounds, but they're looking really broadly at men of African American descent. They're looking in Asian populations to really understand the variations that's happening in that space.
And that's one of the big strengths of Ironman and a lot of the Movember initiatives is it's not just focused on one particular area or population. We are getting a good snapshot across the world to try and figure out what we need to do next. So it was great to get that update from Dan George. And then, but you also sit over a lot of the other GAP programs. So have you any other highlights you want to tell us about the current GAP programs, or indeed future directions of research for Movember globally?
Yeah, sure. Look, I think the GAP programs have really made quite a substantial impact in the prostate cancer space and testicular cancer. And I look back at GAP2, which really played really early on in the PSMA theranostic space. And so to see some of that early work with people like Louise Emmett on GAP2 now then having an impact, now getting drugs to market is really quite impressive. So it's great to see the impact that GAP has had in this space. And now what we're doing is, by me coming to meetings like APCCC, Movember's really trying to understand where do we need to focus next from a strategic perspective, what's the greatest unmet need, and then out of that develop new biomed programs that will address those unmet needs. Part of that sort of sits within the real world evidence network. Yes. So it is establishing these new GAP version 2 type programs that will really look at active surveillance as one of the areas that we've identified, as well as trying to reduce the amount of men that progress to advanced disease. So
fantastic.
A lot of work to be done.
Go Movember. See you back in Melbourne.
Yeah, I'm looking forward to it.
Thank you, Jane Fisher. So, Jochen, one of our favourite topics, radio-guided surgery, PSMA radio-guided surgery. We've had a couple of publications in recent months, nice series from the Netherlands, led by Henk van der Poel and team, Hilde de Barros, showing using this drop-in probe, the Eurorads probe, in the salvage setting. You know, they had very good feasibility, safety, and resected lots of these nodes. Tobias Maurer in Hamburg has had extensive open experience doing this, but of course the real interest is in these drop-in probes for radio-guided surgery. So where do you think this field is at? I think it's an exciting time, it's just emerging, but robotic radio-guided surgery using these PSMA tracers, is it just going to be a flash in the pan, or do you think this is something exciting we need to study?
The nuclear medicine physicians had the great idea to talk about theranostics, which really reflects that we're just opening a book about what we can do with this PSMA as a basic tool for diagnostic and treatment afterwards. And we're now able to see relapsing disease at a way lower disease load than what we could see with conventional imaging. And now, obviously, we would like to target this information we get from PSMA the most reliable way possible. And I think here radio-guided surgery is really the way to go. And we saw that the salvage lymph node dissection, which emerged with choline PET, which is definitely inferior to what we get with PSMA, was not that successful, but because we were unable to get really with a reliable fashion to the node. And nowadays with radio-guided surgery, using PSMA and technetium with it, I think really allows us to do a simple procedure with a tool, with this drop-in probe, which is easy to handle during robotic surgery, during minimal invasive surgery. And with this, obviously, we have a tool to get to this node that are avid, that are containing the tumor or the relapse or whatever you would like to call it. And I think we have a great potential right now to be more effective than what we used to be in this salvage situation, being also less invasive, which is a great advantage as well. We would not like clean the entire lymph node space anymore, and being probably at the same efficacy. So I'm really keen on using this technology in a more systematic fashion, explore it in a systematic fashion inside of a trial and see where we end up with it. If it's for a salvage situation or if it's for initial staging, we just see where it has the most interesting effect for us treating prostate cancer patients, but it does have a lot of potential for me.
And I suppose you just mentioned both those settings. So where PET scanning has really demonstrated strength is in the initial diagnosis of patients and also in biochemical recurrence. But if we find these tiny little lymph nodes on a PET scan at 3 millimeter, internal iliac or almost mesorectal, these are not always easy places to find. They look great on the PET scan beforehand, but when you're in operating, it's not easy to see. So that's the delicious options that the radio guidance will bring us there.
And I even, or you might expect even being more sensitive than what you get with the imaging up front, which takes the entire body, because you're really close to the lymph node, and these probes we currently have are really able to capture a small slight gamma irradiation, and you might even capture smaller lymph node that you cannot see but that you can detect with this tool. And this is where we have, not sure about it, but we have a potential becoming finally better in the management of lymph nodes where we currently know we're not very effective. Several trials show that lymph node dissection is not improving biochemical recurrence because probably not going to the right place in a systematic fashion. And with this approach, we might be way more to the target, to the nodes that are of interest for us, and maybe we finally really improve the outcome of our patient with this approach, no matter if that's, again, at the initial situation or at the recurrent situation.
And the technology looks great. These little gamma probes are now miniaturized and can drop into the robot. There are at least a couple of them now CE marked, and an initial small series are getting going. But there is an interesting trial you and I are both involved with one of these probes, the LightPoint Medical probe, which is CE marked with them, and we will have a PSMA guided probe, hopefully coming from Telix Pharmaceuticals. It is still important not just to get focused on the little gadget, and we do need to do trials.
Sure.
From an endpoint point of view, let's take, for example, the primary staging, initial staging. Your patient has a high-risk prostate cancer, and the Briganti nomogram says they've got a 15% likelihood of lymph node involvement, which means that if you do an extended node dissection, 85% of those patients don't have any nodes involved. The 15% who do have pathological nodes involved may not even need a treatment at that time, plus the morbidity. So do you think that's going to be the sweet spot to say, let's stop doing widespread extended node dissection for everybody, and if we can show in a good trial that the probe is good enough to do selective lymph node dissection with an acceptable NPV, for example, that maybe that will help our patients?
At least that's what probably, being a urologist, I'm most interested in. I like, of course, surgery, but the lymph node dissection is a part that it needs to be meticulously done and takes a lot of time. And if I could skip this part because I'm quite confident that there are no lymph nodes, or I might go only to those lymph nodes that are of interest, I think that's a major game changer for us for doing surgery. And it's better for the patient because we reduce side effects. And in my point of view, the complication rates of prostatectomy are not linked to the ablation of the prostate, but very frequently to lymph node dissection. If we could go around this, I think it's a win-win situation for the patient and a win-win situation for us as well.
Fantastic, exciting times. Thank you, Jochen.
You're welcome.
Christopher Sweeney.
How are you, Declan?
Lovely to see you.
Great to see you.
So Christopher Sweeney has joined. Christopher, I never call you that. You must be in trouble.
Well, that's what my mum says.
Chris Sweeney is joining us here at the APCCC to talk about two things. One was yesterday's fantastic session on combination therapies for metastatic hormone-sensitive prostate cancer, Chris. And of course, we've had all this data on combination therapies, etc., doublet, now triplet. And the field is marauding towards finding the ideal combination therapies. But you presented some beautiful concepts about how the future of these trials might look in terms of, yes, intensification strategies to try and really maximize outcomes for our patients, but also de-intensification strategies. And I thought it was just the most amazing, thought-provoking session. Do you want to tell us a little bit about where you think that field is going?
So, Declan, you've got an international audience here, I suspect. So let's talk about the Bespoke CAP trial.
Yep.
Bespoke being an English word for tailored. And so everything that we've learned over the last 10 years about metastatic hormone-sensitive prostate cancer, we're trying to funnel into this biology-specific, patient-oriented knowledge evolution trial, knowing that some patients have a very aggressive biology and they need a much more proactive therapy, and they may die within a few years of starting their therapy. Other patients live a long time and they may need more of a treatment discontinuation, intermittent, because they could live 8-10 years in the metastatic hormone-sensitive setting. So we need to learn the biology and be specific in targeting that, and being patient-oriented. So, what do we know? We know that patients with presentation at first time with cancer, of prostate cancer, in their bone scans or their CAT scans and multiple metastases, they used to just live 3 years with hormone therapy alone. Now, when we give the intense hormones with abiraterone, apalutamide, enzalutamide, and suspect darolutamide, they will live longer. And we know when we give the chemotherapy to those patients, they will live longer as well. And we'll be showing data from Enzamet soon. And we've also got the data from ARASENSE and from Peace One that giving all 3 therapies up front, more men live longer with that triplet. Now, if we go to the other spectrum of the disease, a patient who presents 5 years later with a rising PSA and 2 bony metastases after their prostatectomy, they never happen after your surgeries. We know this, Declan.
You think?
Or after the radiation and the hormones.
Yeah.
Then we know...
Different type of patient. I think,
Different type of patient.
They're starting from a different start point. Yeah.
Exactly. So they have a slower relapse. Their tumours grow slowly from a micrometastatic lesion to something that we can see. They live longer. And we know that intense hormones work in that group, but we know chemotherapy doesn't. So with triplet doesn't make sense for those patients. We'll find out, I think. Hint.
Yeah.
Whereas it does definitely for the de novo high volume. Then we've got the intermediate group, the patient who presents with 2 bony metastases, a couple of lymph nodes as their first presentation, and disease in their prostate. We know radiation and the intense hormones work really well individually. Chemotherapy is a bit of a plus minus, but the triplet there, I think, will be the radiation, the hormones, and the intense hormones and the radiation. And then there's this rare group who relapse after the prostatectomy with multiple bony metastases or their radiation.
Yeah.
And I think the intense hormones work well. Sometimes we may want to give them the triplet. So that's the story with the Bespoke CAP. Is patients will enter into the trial. They'll get registered based on their profile.
Which of those sorts of patient they are.
Correct.
Yeah.
So you, the physician, and the patient can discern what's the right treatment for them, get 6 months of therapy, get their profiles of the tumours, and then and at 6 months we'll see if their PSA is less than 0.1. Do they have a good response? Can we consolidate radiation, treat for 2 years, and if they're still in a great remission, stop therapy and see how many patients can have a long time off the hormones and restart if things flare up again, and just have a quality of life with hopefully normal testosterone off the treatments. If you have a really aggressive tumour, we may actually want to intensify the chemotherapy, and there's a potential scenario of that with giving maybe platinum with the docetaxel. But if your PSA is more than 0.2 at 6 months and you have a DDR mutation in the tumour, we'd see if you adding the PARP inhibitor has a benefit. If you have an AKT activation, does the AKT inhibitor work, which we see? And if you have residual PSMA PET positivity, does adding lutetium PSMA PET? And this all goes along with the phenomena that what we see is resulting in prolongation of survival in castration-resistant. Move backwards into hormone-sensitive and add that to our therapies and see if we can make men live longer with better quality of lives in the hormone-sensitive space instead of deferring everything until castration resistance. But we realise some patients do really well, so we'll de-intensify some.
Yeah.
And then other patients need more intensification, and can we be targeted and really go after that?
So we're showing the graphic for our YouTube viewers here, but if you're listening on Spotify, I'm sorry. Hopefully you can make sense of that, or maybe we'll tweet out a link to the slide. But as you can see from what we're showing on the screen now, this is beautifully laid out. The flow is really good. And I think the way you've summated those patients into the different types of categories just flows beautifully into the trial. So what's the plan for Bespoke, Chris?
Socialise it.
Yes.
Every social
This is a great meeting to socialise it. We're all interested.
So we got the MRC team, we got the So Good Spanish team, we got the prostate cancer clinical trials team, we got the ANZUP team, we've got Cancer Trials Ireland. It would be great if we could get the Latin American team involved somehow, and an Asian community. So we're trying to get a global community together because we'll need a global registration project where everyone gets registered from around the globe and then gets funneled into the right trial. Does it sound like a big goal? Yes. Are we afraid of big? A little bit.
Oh, come on. No, you're not. I was waiting for the boom moment. Yeah,
But we're going to give it a shot.
Think big. Look, I think it's a brilliant idea, and you can sense at this meeting you're getting a lot of enthusiasm from your partners around the world. And
the collaborations have to be the cooperative groups, the patients and the pharmaceutical industry and the government. And hopefully we can actually show that we can actually maybe get the governments to support this as well, saying if we do this, we'll actually save the insurance companies, the payers, the governments less. Save them money so treatment will cost less.
And even from a clinical trial point of view, setting up a brand new phase 3 clinical trial is so expensive and so on. Whereas within this, embedded within it, will be the opportunities
just roll in the different sub
like
projects.
Stampede gone, plus.
Oh yeah, this is Stampede gone wild.
Yeah. So look, fantastic, and that was one of the highlights of the meeting. I think that yesterday. But the other thing we wanted to speak to you about is about your future plans personally, because of course it was announced in the past year that you're leaving Boston and coming back home to Australia, back to Adelaide. And at the moment, I think you're in a bit of a transition phase. You got one foot in the Adelaide camp, and and you'll continue to have a foot, I'm sure, at Dana-Farber as well. But it's a very exciting looking position back home, your hometown in Adelaide. Can you tell us a little bit about what you're going to do and what we can look forward to?
So I have been given the great honour to be the inaugural director of the South Australian Immunogenomics Cancer Institute, which is going to be based in the University of Adelaide. And there's been an $80 million establishment grant from the federal government. And so we're going to invest that on bringing new talent, new resources into South Australia and have it develop as a collaborative hub where we have great science, great collaborations across South Australia, and we'll bring in a translational component based at the University of Adelaide who works with the clinical trial centres and the patient care, and it's going to be focused on hormone-dependent cancers is one program. Big investment in bioinformatics because data is going to be king and queen of how to manage cancers. Hormone dependence, obviously breast and prostate and ovarian and the like. Another one devoted to epigenetics and the transcription factor of dysregulation. Another one is going to be, we've got a proton center, so there's going to be neuro-oncology and pediatric oncology and radiation biology is a program. And another one is going to be resistance prevention. And so what you're just seeing is that these 5 programs are going to be histology agnostic, and so we're going to be going after biology and data and see if we can learn from one tumour and apply it to another and go backwards and forwards and be biology specific again, and see if we can really develop new knowledge on how to not only treat advanced disease but prevent the development of cancer, and for those who start therapy, not try and overcome resistance, but prevent resistance.
Fantastic. Well, so we thought that talking about this first Bespoke trial was a big deal, but take a listen to the scope of this program. It's amazing, Chris. And look, we're all very excited to have you back home personally in Australia as well. We look forward to that. But I think the vision you have for both that type of trial like Bespoke and for this type of centre will just reverberate around the world, and we wish you all the best with it.
We're going to do it together, Dad.
All right. Good. Thanks
Cheers,
very
mate.
much.
Cheers.
We also want really to remind everyone that there will be a new one in Lugano again, because I was asked that a lot. So yes, it will be in Lugano again. I hope that's fine for everyone. And it's 25th to 27th of April 2024.
So that's it. I do hope you enjoyed these 3 episodes of GU Cast coming to you from the APCCC here in Lugano. Congratulations again to Silke, Gillessen and Aurelius Omlin for putting on this fantastic meeting. It really has been one of the most enjoyable meetings I've ever attended. And of course, it's a virtual meeting, so you can still go online and get a registration and watch this content over the coming months. We'll put a link in our show notes below. Of course, a big manuscript is going to follow from this. The traditional APCCC document will come out, which is always very highly cited, always a really good reference for helping decision making in these difficult areas of prostate cancer. And of course, there'll be another APCCC here in Lugano in 2 years' time. The dates have already been announced. We'll put a link in our show notes. Put the dates in your diary. I highly recommend this world-class meeting.